to shed more light on this promising alternative, next we're joined by an industry stalwart. He joins us all the way from Paris to share his take on new age best practices in the field of critical care. Ladies and gentlemen, please put your hands together for Professor Jean-Louis Teboul, Professor Emeritus in Therapeutics and Critical Care Medicine at Paris Saclay University, France. Sir, the floor is yours.
Thank you very much for this very nice introduction. So I'm very happy to be here, to be honest, very happy. And I thank a lot the Dozee team for this invitation. I am happy and honored to present today. I would like to convey my enthusiasm to you for blood pressure monitoring. And I would like to go back to basic physiology first. This is my conflict of interest. Just for people who does not know me, my research, my main research is in the domain of hemodynamics and especially hemodynamic monitoring in ICU patients. So I would like to go back to basic physiology to well understand how to use blood pressure even with the Dozee system. You will see. I want to go back to the determinants of aortic pressure. As you know, aortic pressure is a complex result, thank you, of ventricular ejection and elastic and resistive characteristics of the arterial tree. And the cardiac pump generates a pulsatile flow. The arteries are elastic structures that amortize the discontinuous cardiac ejection by storing a part of the stroke volume during the systole in the walls of the aorta. Like this. There is a storage. And this is restituted during the diastole. And therefore, this contributes in part to the arterial pressure waveform. So the main determinants of aortic pressure is stroke volume and aortic compliance. Indeed, in case of stiff arteries, there is no storage or almost no storage during the systole because of the stiffness. And therefore, there is a decrease in the pulse pressure, but also a decrease in the diastolic flow. Diastolic flow is very important. What happens during the diastole is very important for the body. There is another phenomenon, which is very interesting to know. Of course you know. This is a reflection waves phenomenon. In fact, the arterial pressure wave gets reflected every time it meets areas of change in impedance. In fact, bifurcation areas, like this. Every time it meets bifurcation, it comes back to the aorta. So, summing many reflected waves phenomena result in a reflected wave in sum of the reflected wave which elevates the aortic pressure with a maximum at the beginning of the diastole. And this is good. This is good for the body. And the reflected wave, the final reflected wave from the periphery, is superimposed with the incident wave from the heart to generate the aortic pressure, the final aortic pressure. This is physiology. And the shape is like this. You know the shape of the aortic pressure. But, there is always a but. But, if the compliance of the aorta, or the arteries, is reduced due to stiffness, or if the reflection site is more proximal due to vasoconstriction, the reflection waves return faster faster to the aortic level, so that the reflected wave occurs earlier and not in the diastole, in the systole. It's not good. It's not good because you should have a higher systolic pressure and a lower diastolic pressure. Again, what is good for the body is the diastolic pressure. Therefore, you have an increased risk of stroke, because the stroke can be created or influenced by the systolic aortic pressure. Also, you have an increase in the left ventricular afterload due to this, and this reflected by the area under the curve, the systolic portion of the pressure, which reflects the left ventricular afterload, and there is an increased myocardial oxygen demand in this case. And finally, a decrease in the aortic pressure, and thus in the coronary perfusion pressure, with an increased risk of myocardial ischemia in some predisposed patients. So you will understand that if the arteries are stiff, there is all these risks. It's bad for the body, of course. So to summarize this boring part, the diastolic part of aortic pressure is a result of restitution during diastole of the blood volume stored during the systole, and the reflection wave phenomenon in patients with elastic arteries. And therefore, in patients with stiff arteries, the diastolic part of aortic pressure is reduced. Okay, this is for the aortic pressure. But what we measure in general, in ICUs or in the general wards, is the peripheral pressure, not the aortic pressure. So the question is, does peripheral pressure differ from aortic pressure? Yes, no, it depends, as always. In fact, yes, this is the central pressure wave, aortic pressure if you want, and due to the pulse wave amplification phenomenon, there is an increase in the systolic pressure in the periphery compared to the central site, and a small decrease in the diastolic pressure. So therefore, it's normal to have aortic SAP and pulse pressure lower than the femoral SAP and pulse pressure, and lower than the radial SAP and pulse pressure. This is normal in normal, I would say, normal people, young people, in fact. We can be old and normal, but in fact, due to aging, we have stiffness with time. So there is a large amplification when the reflected waves return slowly and thus do not increase the systolic aortic pressure. And this happens in young, normotensive, vasodilated, tall people. Tall because the site of reflection is far from the heart. But there is a small amplification phenomenon when the reflected waves return fast, and thus will increase the systolic aortic pressure, and there is a quasi-equalization of the systolic pressure in the aorta and systolic pressure in the periphery. This happens in all subjects, in hypertensive people, vasoconstricted, short size. So now, and this is what I want to insist on, is what is the physiological meaning of the peripheral arterial pressure? What about systolic arterial pressure? So at the level of aortic site, it is a good reflection of the left ventricular afterload. I don't want to go into details, too much details. But at the peripheral site, is it a reflection of left ventricular afterload or not? It depends. Yes, if there is a low pulse wave amplification phenomenon, because we have quasi-equalization between the systolic aortic pressure and the peripheral. And you can say, if you measure the systolic pressure, you have a good idea of what is the left ventricular afterload. But, in other words, for a given SAP. For example, 140 millimeters of mercury. The left ventricular afterload is higher in patients with stiff arteries than in those with normal compliance, because in the second example, in aorta, the systolic pressure is lower, maybe 120. What about MAP? MAP is very well known. This is close to, in periphery, it is close to the central MAP. And MAP is cardiac output times systemic vascular resistance plus P0, which is in general CVP, central venous pressure. So again, what is interesting in MAP is that it is almost the same, similar, in the periphery and the aorta. Femoral MAP equals radial MAP equals aortic MAP. The meaning, interestingly for us, for intensivists, is that this is the upstream pressure for organ perfusion, for the kidney, for the brain, etc. We know this very well. I will go very fast to say that if the MAP is below a critical level, there is a decrease in organ blood flow if MAP decreases further. And this is the definition of shock. And our job as intensivists is to try to push the MAP on the plateau of the relationship. So it is an important target for resuscitation of patients with shock. What about DAP? I like DAP. DAP. Because DAP is a good reflection of the vasomotor tone. A low DAP is mainly due to a depressed arterial tone. So you have the information just in front of you. If you measure DAP, you know what about the arterial tone. But we should know that DAP also can be low in case of arterial stiffness, but not as low as in case of low vascular tone. But also in case of bradycardia, but this is not very common in ICU patients. So to take into account heart rate, it is possible to look at the diastolic shock index. This is what we proposed some years ago with Gustavo Spinatascon, Glenn Hernandez, and some friends from Latin America. And we propose to look at the ratio of heart rate divided by DAP as a good marker of vascular tone. It was better associated with mortality than the diastolic arterial pressure alone. Interestingly, DAP also is important because this is the upstream pressure for the left ventricular coronary perfusion. And this is very important also to keep in mind. Pulse pressure. I like pulse pressure. I like pulse pressure because pulse pressure at the aortic level is simply related to stroke volume and inversely related to compliance or aortic stiffness. So if aorta is stiff, pulse wave amplification is attenuated, as I told you before, and therefore the peripheral pulse pressure should reflect the aortic pulse pressure. So the same information can be drawn from the pulse pressure in the periphery as a marker of stroke volume. In this paper, years ago, we showed that aortic stiffness and stroke volume were the major determinants of peripheral pulse pressure, especially in patients older than 60 years. And this confirms physiology. Interestingly, at the bedside, if you have stiff arteries and normal stroke volume, you should have a high pulse pressure, around 60, 80 meters of mercury. This is normal. But if you have a low pulse pressure in stiff arteries conditions, this low pulse pressure, 30, 40, suggests that the stroke volume is low. You don't need to measure cardiac output. You have the answer or question in front of you. Pulse pressure is low, the patient is 60, 70, 75. You know that stroke volume is low. In patients with normal arteries, It is hard to assess stroke volume from peripheral pulse pressure, to be honest, because in this case, it is better to have an estimation of aortic pulse pressure to assess stroke volume and its changes. And maybe with a Dozee system, we can approach the aortic pressure, and maybe this is a good advantage of this technology. So monitoring blood pressure, it is so important in ICU patients. We all know this. And there is a recent paper published some weeks ago in Intensive Medicine, putting 122 articles. Look at the number of patients. A lot of patients included. And this confirms that exposure to hypotension during intensive care unit stay correlated with elevated mortality rates. So this is a confirmation that hypotension is very dangerous for ICU patients. How to monitor blood pressure in ICU patients? Of course, we have the invasive blood pressure monitoring, and especially in shock patients. In this paper, coming from some experts from the ESICM, European Society of Intensive Medicine, we recommended to insert an arterial catheter in patients with shock to better monitor blood pressure, but also for blood gases, sampling, etc. The advantage, it is a reference method in terms of accuracy of blood pressure measurements. Of course, the disadvantages are the invasiveness with many potential complications. You know this very well. And also, we estimate the peripheral, but not the aortic pressure, which is not so good in some categories of patients. Another way to do is to use non-invasive blood pressure monitoring and the classical automated cuff blood pressure monitoring. What is the advantage? Of course, non-invasiveness. And the disadvantage is some discomfort for awake patients, essentially, because you have some regular inflation of the curve and deflation of the curve. It could be also, it could disturb sleeping, etc. And also a moderate accuracy of systolic and diastolic pressures with this technology. And this is well illustrated in this paper. I don't want to go into detail to say that for the mean pressure, it's not so bad compared to the arterial catheter measurements, but for the diastolic and the systolic, it's not so good. Other methods in ICU patients, do you know other methods to monitor blood pressure? There are these methods using the volume clamp technology. You know maybe the ClearSight and the Niki devices, which are now commercialized. They are supposed to provide continuous non-invasive blood pressure. I don't want to go into detail for the technology because we have no time for this. And unfortunately, this does not work very well. This is a meta-analysis by Bernd Sogel, a friend of mine, very good friend of mine, published 4 years ago, and comparing the volume clamp blood pressure to the arterial catheter blood pressure with unsatisfactory reliability for the absolute values. And for the trending ability, not so good. This is another paper coming from France, looking at the changes of volume clamp blood pressure and arterial catheter blood pressure, and the concordance rate was not good enough. 67% is not good. What is better is more than 90%. So now, in non-ICU patients, what to do? We should know that there is a lot of innovative solutions. Look at the number of patents and number of publications from 2000 to 2022. A lot, an increasing number of innovative solutions. And most of them use this kind of techniques. I don't want to go into details because they do not provide, except volume control technology, they do not provide continuous measurements. Continuous measurements. They provide punctual measurements, spot checks. And the only one to provide continuous measurement was the volume clamp method, which is not very good when compared to the arterial catheter measurements. So there is a critical need for non-invasive, non-contact, continuous monitoring of blood pressure to aid in early warning protocols. This is what we already heard today and probably later on. And there is, one technology which was not used a lot before, which is a ballistocartography. I am not an expert of this technique, and probably in another talk later, we should have more information about how does it work. But in fact, it is a non-invasive technique used for recording cardiac vibrations caused by myocardial motion and the acceleration of the blood throughout the large vessels of the body during systole and diastole. And the Dozee system is a ballistocardiogram microvibration-based device consisting of piezoelectric sensors spread across the sheet, which, when placed under the mattress, this is very interesting, of the patient, measures the micro and the macro body vibrations. And there is a processing signal which is filtered, which is processed, which is, and in the artificial intelligence you talk about, the models can use all the features extracted by this system, plus heart rate, plus respiratory rate, plus many other features, and everything can be put in a deep learning system to finally provide change in the systolic and the diastolic pressure. Of course, there is a need of calibration to obtain absolute values. And this is what is in the system with this is a remote system, and using the deep learning model for blood pressure computation, calibration, of course, initially, and then going to the cloud and going to your app. These are unpublished data coming from India, where 69 patients were included, and many number of points, and the non-contact blood pressure model for the systolic pressure and for the diastolic pressure were compared to arterial catheter measurements. As you can see, the mean absolute error, which is the pink area here, was acceptable for the systolic and the diastolic pressures with the Dozee system. But of course, we need more validation. This is just the primary data and published data. And what is interesting is the trending ability. This is an example of one patient comparing the non-invasive at the upper part of the slide. Sorry, maybe I will show this better. Oh, I don't know what to do. And the non-contact in orange, blood pressure, and the green one was the arterial blood pressure using arterial catheter. And you see that the non-contact blood pressure follows the changes of the arterial catheter blood pressure. So the advantages, and we'll finish in a few seconds, the advantages for me of this technique is to be non-invasive, to be continuous, and this avoids regular time-consuming spot checks by the nurses, and this tracks any clinical deterioration. This is very important for us. Contactless, there is no discomfort for the patient, easy nursing and easy other interventions, smart and remote monitoring. There is no need for patients monitor with noisy alarms, for example. And it tracks aortic blood pressure. And it's allowing probably more physiological interpretation than peripheral measurements, as I tried to explain at the beginning of my talk. And probably it is an ideal tool for the general wards, of course. Not for the ICU patients, of course, not for patients with shock, but probably to identify patients in the general wards who can be transferred to the ICU, who can experience some clinical deterioration, etc. So it is promising, but needs more validation. Of course, we need more validation compared to arterial catheters in many, many conditions. In many, when vasopressors are used, when vasodilators, I would say, because the vasopressors are not used in the general ward patients, but maybe vasodilators or other interventions. Thank you very much for your attention.
Professor Teboul, I have to thank you for that incredibly comprehensive overview. And ladies and gentlemen, it's not every day that we receive a front row seat to such groundbreaking research from an internationally recognized thought leader. So huge round of applause for Professor once more.